Good morning, everyone. Welcome to the Project Pain 2.0 webinar. Just looking and waiting to make sure we get some more participants. We see a lot of guests are joining us this morning. Good morning, everyone. We will be getting started very shortly. Just waiting for a few more people to sign in here. Perfect. Perfect. Well, let's go ahead and jump on in. I see we have a lot of attendees this morning. Thank you all so much for joining us. My name is Riley Stith. I am the social media director for Doctors on Leans. And I want to thank you all again for joining us. Due to popular demand, we decided to bring back Dr. Michael Price, Dr. Harold Kraft, to have a more detailed discussion about PRP, no needle laser therapy, and pain management. Our moderator today is Ali Razavi with Razavi Law Group, and we are very excited to have you all. So we're going to go ahead and introduce our guests and our panelists this morning. Our first panelist is Dr. Harold Kraft, crafting the perfect pain plan with no needle knowledge. Dr. Kraft is a board certified physician, founder of No Needle Epidural. He's a member of the American Society for Lasers in Medicine and Surgery, the International Association for the Study of Pain, and the American Academy of Pain Management. Thank you so much, Dr. Kraft, for being with us.
Thank you.
Our next panelist is Dr. Michael Price, who will be doing a spin on alternative injections. Dr. Price is board certified in orthopedic surgery and regenerative medicine. He is the medical director for Pledge Medical, and he's with offices in Newport Beach, Long Beach, Bakersfield, Riverside, and more. So thank you so much for being with us, Dr. Price.
My pleasure.
And our moderator today, as I mentioned, is Ali Razavi, founder and managing attorney at Razavi Law Group. Pursued his law degree at Chapman University's reputable Fowler School of Law, has been solely focusing on civil litigation and alternative dispute resolution, and has reached hundreds of successful resolutions for his clients. Ali, thank you so much for moderating today.
Thank you, Riley. Welcome, ladies and gentlemen, to Project Pain 2.0. My name is Ali Razavi, and I will be your moderator today. Did you know, according to a 2016 US study, 1 in 5 Americans suffer from chronic pain? That's over 50 million people. Statistically speaking, that's either you or someone that you know very well. Today, we will be speaking about pain management, needle-free laser therapy, and PRP, platelet-rich plasma. We have 2 doctors, 2 approaches, and 1 common goal of being pain-free. Today's format will have each doctor explain their process and will allow some time for Q&As at the end. So without further ado, Dr. Harold Kraft from No Needle Epidural, please take the stage.
Thank you, and welcome everybody. So can you all hear me? Yes.
I can hear you. Dr. Kraft,
Good.
I think we just need to fix your camera because we cannot see you at the moment.
Okay. Sorry about that.
No worries.
Let me see here.
Yep, you just need to flip that around. Perfect.
I see. It's hang on 1 second. It suddenly flipped to the other side. Give me 1 second.
No worries.
There we go.
Perfect.
Okay. Sorry about that.
There you are.
Good. So today we're talking about no needle epidural. It's an alternative to traditional epidurals. And if you want to flip on the slideshow, Riley, thank you. Great. And so if you just advance to the next slide, just sort of in summary, starting with a summary first in case anybody has to go, no needle epidural is more effective than PT or chiro. It's roughly half the cost of an epidural. gives you better relief than epidurals. It decreases inflammation. It attacks the actual problem, and it's faster than PT or chiro. It is, however, slower than epidurals. That's the overall summary. Everything else we're going to talk about is a detail based on that. If you go to the next slide, I spent 20 years as an anesthesiologist giving anesthesia and epidurals mostly on the East Coast. I started no needle epidural laser practice in 2015. 80% of my practice is Medicare and PPO, 20% is personal injury. And roughly half of my patients have failed either surgery or epidurals before. I have the most laser experience in the country, which consists of about 25,000 treatments. So Riley, if you can hit the next slide. What is a no needle epidural? It's basically a laser. It's about this big around, and it's a high-powered laser between 25 and 100 watts, which is quite powerful. It can easily burn things if you don't know what you're doing. It is FDA approved. And Riley, if you can go on to the next slide. How does no needle work? The primary mechanism is that you laser the body, a part of the body, and the body will secrete anti-inflammatories. So if you imagine where typically an epidural is done in the back, either the neck or the lumbar region, that's roughly the same region we typically treat. We also treat peripheral musculoskeletal and joint problems. Anti-inflammatory action is effective on all soft tissue and all spine and nerve root and bone problems. Basically, any tissue in the body can secrete its own anti-inflammatories. The laser just accelerates the anti-inflammatory benefits. It also helps tissues heal. So in the event of a fracture, a sprain, a strain, the laser will help accelerate the body's own natural healing process. The laser can reach about 3 inches into the body. Riley, if you want to go to the next slide. As general guidance for why you use a no needle epidural, I typically tell lawyers and law firms that it's a step in between where you might want to start chiro or PT and epidurals. Some people actually start with, a lot of my patients actually, and some lawyers, clients start with a no needle epidural because it's so effective and it's pain-free. In terms of your settlement costs, it's going to end up, after all is said and done, to be about half the price of epidurals. So costs a little more than PT, half the price of an epidural typically. It treats the root cause of inflammation. This is not a cover-up. This is not a narcotic. I actually don't prescribe any narcotics at all in my practice. And it's effective for more pains than an epidural will treat. An epidural, which can be great, just only treats the nerve root inflammation. The laser can treat all the soft tissue inflammation plus the nerve root inflammation. Riley, if you go on to the next slide. We typically treat multiple regions on each visit. So if somebody has neck pain and lumbar pain, we'll treat both. If they have their elbow or they're grabbing onto the steering wheel, they have wrist pain and elbow pain, we'll essentially treat almost all pains, musculoskeletal pains that the patient has. Typically, this is 2 visits per week. On average, 12 visits to get everything done, sometimes more, sometimes less. We invoice at about $1,000 per visit just for your budgeting, and that ends up being about half the cost of an epidural in Los Angeles. Riley, if you flip to the next slide. Biggest question that I often get, aside from how does insurance feel about this? We've done about, I only started in personal injury about a year and a half ago. So we've settled about 100 cases, 100% settlement rate. 100% have successfully settled. Obviously, we don't get 100% of the invoice. And we've had a couple of payers push back and want references, which we provide. A couple have asked questions of the lawyer. The lawyer usually kind of swats them away if there are questions by simply saying, look, this is half the cost of an epidural. What more do you want from my client? So we've had very luckily 100% settlement cases settle. There are some cases, patients you have where you should consider no needle epidural almost at the top of your list. First case, we're in Southern California, so there are people who either say no needles or I don't want any drugs in me. By the way, I'm not opposed to epidurals. I love epidurals. I tell every patient that. I used to do epidurals, they're great. If this doesn't work, then you need to move on to another treatment, and there's nothing wrong with considering epidurals. So I do not dissuade people personally from having epidurals. I think they're great when they're necessary. But if your client doesn't want needles, they don't want any drugs in them, then think about no needle. If you have a limited budget, we can work within that budget. We don't have to do 12 treatments. We can do 2, 4, 6 treatments in the small cases. If you have pain outside of the spine, Dr. Price has a lot of experience with his therapy, PRP. Outside of the spine should not be relegated to A, we can't do that, or B, the chiro didn't help you. There's Dr. Price, there's no needle, there's all kinds of alternatives. And Ali, you mentioned that a lot of people have chronic pain. A lot of that chronic pain started with motor vehicle accidents where the patient did not get good treatment initially.
Right.
You can consider at the top of your list no needle epidural when epidurals did not work. So epidurals only have about a 60% efficacy rate, which is the same as no needle epidural, but it's a different 60%. If you have a pregnant patient or the patient is on blood thinners, no needle epidural should definitely be considered. I don't laser lower back pain in a pregnant patient, but I can laser all other pains in a pregnant patient. And in the case of nerve injury, crips, traumatic brain injury, we can help as well. Next slide, if you would, Riley. So there's a treatment waterfall, and everybody, all the case managers have a treatment waterfall. Dr. Price has one. Every doctor you talk to has a treatment waterfall. And if you're talking to a physician, every physician, including myself and Dr. Price, wants to move their treatment up in the waterfall. But I think this is sort of a generic waterfall. For spine, you start with PT or chiro. If that doesn't work, you go to no needle. If that doesn't work, you go to a big needle epidural, PRP stem cell, followed hopefully last by surgery, and the unfortunate few people who need a spinal cord stimulator. For joints and peripheral pain, PT and chiro, consider the orthopod or the treating physician will consider cortisone or trigger point injections, followed by no needle, PRP, stem cell, and lastly surgery. So there are many treatments that we have available now. Dr. Price is going to talk to the PRP, which can be very helpful in the waterfall as well. Let's, Riley, if we could go on. One question I get often, and I not just about epidurals, but sort of what is the gold standard? And are epidurals the gold standard? And this is just a little pushback about the so-called gold standard, which are epidurals. The gold standard of evaluating mechanisms is the Cochrane library. They produce Cochrane reports. These are reviews of reviews. And it's sort of the highest standard in the land, internationally even. And their conclusion about epidural steroids is that they're basically not really that great. We've all had experiences. I've had many, many experiences where I give an epidural, the patient is cured, literally cured forever in one epidural. So we all know they're not great. But if you do the numbers, the epidurals are not as gold a standard as people claim. So whenever anybody asks me if no needle epidural is as good as epidural, the first thing I say is epidurals are not really as good as we're all thinking. And the second is they're both at 60% efficacy. So Riley, if you go on to the next slide, sort of the wrapping up, where can you get no needle? I have offices in Santa Monica and Manhattan Beach. We have all kinds of hours that are friendly to either working clients or people with kids. We're open 7 to 7 plus Saturday. Coming very soon are offices in Sherman Oaks and Torrance. You can find us through the Doctors on Lean's directory, or of course on the web at www.noneedleepidural.com. And Riley, the final slide just covers everything that we started with, which is it's generally more effective than PT or chiro, half the cost of an epidural, better relief than epidurals because we treat the nerve root plus the soft tissue, sprain and strain, and it decreases inflammation of every tissue that we laser, and it's generally faster than PT or chiro, but slower than epidurals. So that's it for me.
Thank you so much, Dr. Kraft. That was so helpful. From a personal injury attorney, from a personal injury standpoint, this is amazing, right? I can't tell you how many times I've had this impasse with a client and the insurance company. Clients clearly in pain, but they don't want to get the injection, but they're in pain, and we can't do conservative treatment for the rest of our lives. So now the client thinks, well, my attorney sucks because I'm in pain and I'm not getting full value for my case now. So this is great. We have an alternative to clients that don't want to have any injection. So thank you for that. While you were giving this great presentation, we had some questions come in. Some of it you've already touched base on, but just to go over it again, how does no needle epidural compare with regular kind?
So a no needle epidural, you can think of as in both cases, if the patient has a disc protrusion and nerve root injury, we'll just say in the lower back, the no needle, their standard epidural, it's not quite as big as my pen, but it looks that way to a patient. An epidural needle is about 3.5 inches long and almost as big as my pen, and it goes in right by the nerve root. It's pinpoint. It injects a little bit of steroid right by the nerve root. It does nothing for the muscle, for the bone, for the sprain, the strain, but it does reduce inflammation of the nerve root. The laser is about, it's a little bit bigger than this marker. It's about 2 inches across, 3 inches across. It's completely non-invasive. Instead of being pinpoint, we laser a region of the back. So we get the nerve root inflammation quieted down, and we get muscle, the joints, the facet joints, and any other inflammation also gets reduced.
Understood. Thank you. And what's the general cost for this?
Basically, the invoice price is $1,000 per treatment. Typically, 12 treatments on average. We can work with a smaller budget. If somebody needs more, we'll ask for more. And some people actually get. I've had a lot of patients who get significant, almost complete pain relief in under 6 treatments. But we we work with the attorney to determine if we should either cut it while it's a minimized bill, or if you just want the full 12 times $1,000 each.
Understood. So what I'm hearing, you're pretty flexible here.
Well, we definitely want to work with as many attorneys as possible by helping them help the client.
Perfect. I appreciate that. What are the special conditions that are better or worse for no needle epidural?
There are very few that are worse. Occasionally we get somebody who is super sensitive, but that's about, it's less than 1% of my patients. The top indications, if you will, where somebody should be driving across town, it would be pregnancy, blood thinners, I don't want any drugs in me, and people who are truly deathly afraid of needles.
Like myself.
And like me. Epidurals, I should tell you, I love epidurals, but they're better to give than to get.
I hear you on that. How many sessions does someone need before they see results?
So the most commonly, people start seeing results at 4 to 6 treatments and almost no results before that. But about 20 or 30% of my patients will be early responders, and they'll feel better after 1, 2, or 3 treatments. I usually tell patients you'll feel nothing for 4 to 8 treatments.
Got it. And again, how did you get started with no needle epidural? It's so interesting.
So that's a crazy, it's a crazy answer. It involves my wife's dog and a former patient, but anybody who calls me up, I'll be happy to tell them the full story.
Amazing. Thank you. I know so many personal injury attorneys in the field that want to know, will insurance cover this?
Well, yeah, so on 80% of my business is Medicare and PPO. We just bill commercial insurance companies and Medicare. And the 20% of the business, which I think is what you're talking about, the personal injury, we've had 100% of the plaintiffs' insurers cover this. Sometimes they need a slight push, but I think that's very typical. They're doing their job and you're doing yours.
Amazing, amazing. Is there any risks or side effects to these no needle laser therapies?
If it's done right, the risk is extremely small. The major risk is a thermal injury. We don't like the word burn here, but the major risk is a thermal injury. Out of 25 to 30,000 treatments, I've had 3 of those. So about 1 in 5 to 10,000 treatments results in an injury to the patient. So it's not 100% risk-free. There's, in my opinion, I think Dr. Price would agree with this. There's no treatment in the world that works that's 100% risk-free, but it is very low risk.
Amazing. Is this done at a surgery center or at your office?
No, we do it right in the office. It's one of the few treatments that's very pleasant. You sit in a massage chair. When I did my epidurals, I always had the patient sitting up. So I carried that over here. I like the midline approach. So if we're doing a neck or lower back, you sit in a massage chair. If we're doing a shoulder, you can just sit in a regular chair. But we only laser skin, so it's a very clinical but pleasant approach.
Perfect. And this is a question, I mean, in practice, how does this work? What type of referral or prescription do we need to get this laser therapy for our clients or patients?
You just call our office. I'm a physician, so I don't know particular referral is needed. Just call us, ask us to evaluate the patient. We see the patient, we usually give them 1 treatment. We generate a consult where we recommend 12 treatments and send the medical record over and a lean form and you're good to go.
Amazing. So either you're going to be the PTP, primary treating physician, or if some conservative treatment sends them over to pain management, you'll take over from there.
Either way is good. The only small caveat is that I used to be on the East Coast. When I came to California, I deliberately did not get my California DEA, so I cannot write narcotics, and I prefer not to write other prescriptions, although I can and do. But you know, I'll be honest, most of the personal injury patients I get, almost very few are drug seeking, and the attorneys are all extremely good about you get your pain fixed, and not some Band-Aid.
Understood. Thank you for that. And the procedure itself, how long is the procedure?
The very first visit, it might be as little as 5 minutes. We start off with a smaller dose and go up to bigger and bigger doses. Somebody who's larger than average person getting multiple treatments, it could be a 30 to 35 minute actual laser time.
Understood. Okay. And then again, in practice, would you need diagnostic testing beforehand, MRI, CT scans, things of that nature?
I personally, on my PPO Medicare patients, I rarely get MRIs. If they have one, I look at it. For my lean patients, if they come to me de novo, then I try and get at least 1 MRI for the legal record. Occasionally, I need one. I can order any MRI, so I just send you the MRI request. I don't. If you're trying to minimize costs, however, our baseline is to not order any MRIs unless the origin of the pain is not clear.
Understood. And if the MRI or diagnostic testing is fairly negative and clean, is this still a procedure that would be helpful if they're feeling pain?
If the patient has pain, yeah, I think the problem with people who have chronic pain is that they were treated by either a surgeon or with epidurals or some other technique in the past where they treated the MRI and the patient, they treated the wrong thing. The fact that there's a disc protrusion, and I'm sure Dr. Price would agree with this, the fact that there's a disc protrusion does not mean that that's the origin of the problem. You can have facet joint pain, soft tissue pain, all kinds of pain, where an epidural simply will never work and will never show up on the MRI as a problem.
Understood. Okay, thank you. And You know, I'm still hearing from the crowd. They really want to hear how you got started in this.
So I'll tell you too. So actually, first of all, I lived on the East Coast. My wife still works. She's a lawyer for the government, so she works back in D.C. I came out to California. My wife's dog. When I die, I want to come back as one of my wife's dogs. The dog stopped walking as a pug, and doggy PT, doggy acupuncture, doggy supplements, nothing worked. And the vet said, let's laser the dog. And I truly saw with my own eyes, the dog went from not walking to walking. But I thought, it's my wife's dog. No person's ever going to get this kind of treatment. A former patient came down who's also a friend of my wife. Her back went out. I could never fix her back with epidurals. My wife took the lady to the vet. They lasered the woman's back, and she got better than I could ever get her with epidurals. So I started to look into it. And indeed, there's a tremendous amount. I still didn't believe it. I'm a physician I've spent 20 years giving drugs, shooting people up in the OR. I live by physiology and pharmacology. So I actually rented a subletted office in Manhattan Beach with a month-to-month lease because I didn't believe it would work. I lasered my own pain and it worked, and then I hung my shingle.
Amazing, amazing. That's a great story. I mean, I can't even believe you worked with a dog beforehand. One final question. You know, there's epidurals, there's radio frequency ablations. I mean, a lot of these procedures, it's a lot of maintenance, right? I mean, I see the recommendations from the doctor, you know, come back every time you have pain, come back every few months, come back once a year. Is that the same with laser therapy from your experience?
Well, there's two answers. For chronic pain, sometimes we can treat. I have some patients with spinal stenosis, which is a chronic condition you get usually sort of 50 and above. I've had some spinal stenosis chronic pain patients who get permanent pain relief. I know that because I might see them for other things. For one of the reasons I love working with personal injury patients is they usually have acute pain, and when you have fixed their inflammation, either with Dr. Price or with no needle epidurals, you have fixed them. They don't need to come back. I'm more than delighted when somebody says, I'm good to go. I always tell the patient to increase activity as we go along. And my goal is to get them permanently better. So I believe, and I actually dislike when a person shows up and after a few months and says, you know, I'm just here for maintenance. I'm thinking, why are you wasting my time and your time? So the answer is no. There is no need for maintenance. If you're cured, you're cured.
Okay. And just so we're clear, the body parts that we can do this is your joints, extremities, knees, elbows. Does it work for TBIs as well?
Yeah, so it does work for TBI. It's a phenomenal TBI treatment, but it's off-label for TBI. So if somebody I'm probably at the top 20 in the country who've treated in terms of my TBI number of TBI treatments for this. It is phenomenal for PTSD and TBI, but off-label. Please contact me.
Sounds good. And we're going to provide everyone's contact information at the end, so they can contact you directly via email, and we'll provide that for the audience.
Great.
I think as of now, these are the questions. If more questions come in, thank you for answering them. Truly, I appreciate that.
You're welcome.
All right. And next we have Dr. Michael Price from Pledge Medical. Dr. Michael Price, please take the stage.
Good morning. Well, I wanted to point out that I thought the no needle epidurals is an excellent treatment. I like it because it really follows some of the same principles that I follow with PRP, which is not introducing foreign materials into a patient's body, because that's some of the biggest complaints are side effects from injections using steroid, and of course, usually there's some local anesthetic, but some of the preservatives in some of those materials can cause systemic reactions, increased blood sugars with the steroids. So I think that I'm impressed with this lecture that it follows those same principles. Not to mention, some of the early work with PRP and stem cells was done in animals, in fact, horses. So if there's any horse people out there, you probably knew about stem cells and PRP long before we were using it in clinical practice. So interesting to hear that it came from a veterinary source where some of the results were started to be seen. So anyway, moving right along, I wanted to show just a brief 60-second video, which is basically a PRP I did in the office, and then we'll talk right after that, just to show you what we do. PRP stands for platelet-rich plasma. It's the act of removing blood from your body, spinning your blood, extracting your plasma, and then injecting it back into you in areas where you have pain to help promote healing, ultimately to make you feel better. From start to finish, the process of getting a PRP injection is about 30 minutes. After you've had your PRP injection, you just take it easy that day, but the next morning you wake up, you can do anything you want, almost no downtime. The physicians at Pledge Medical have been doing PRP injections for almost 10 years, so we're very aware of the safety and the benefits of using PRP. If you'd like your patients to come see us for an evaluation, we'd be happy to do so and give you recommendations accordingly. Yes, as Jerry pointed out, those are her knees that we did there. So I just wanted to show you an example of how we do that in the office. It doesn't involve any artificial material, or it's just straight plasma, the patient's own plasma that's put back in. The one thing to point out, particularly with injuries such as motor vehicle accidents, is that when there's an injury to the spine, and let's say that there's an MRI obtained after the injury and there's one or multiple discs that are protruding, the important thing to remember is in order for that disc to be protruding, there was an abnormal mechanism at that level of the spine, which also involved injury to all the soft tissues, the muscles, tendons, and ligaments, which encase the spine. So as Dr. Kraft pointed out, with which I agree, there's really multiple levels of injury when there's a spinal injury from some kind of torquing, twisting, or whiplash injury, as opposed to just a straight degenerative condition. So when you have a patient like this, it's important to recognize it. I also think that epidurals have a definite place in pain management for radicular symptoms with pain shooting down the arms or legs from an obvious disc herniation. But other than that, you can really go with these non-invasive treatments, of which I do a lot of PRP for this, and it follows regenerative medicine principles. One of the questions that comes up, particularly with primary care providers, chiropractors who are really kind of on the front line of evaluating and treating these patients, is when is the ideal time to send a patient for PRP? And I'd like to reiterate what Dr. Kraft said, which is there's definitely a waterfall treatment, which is, all treatment should start with very conservative methods. The judicious use of anti-inflammatory medications, maybe a short course of muscle relaxers, but not too long, chiropractic physiotherapy, activity modification, all the basic non-interventional treatments. And then if a patient gets to be 6 or 8 weeks after an injury, and perhaps they're in the chiropractor office, and the chiropractor thinks, well, there's this one problem area in the neck or back that if I could get this area to really feel better, I think I could really bring them along much quicker. Those are good times to send a patient for consideration of PRP. I do use the needles, obviously. The no needle epidural does not use needles, so that's an advantage over PRP. But I do use the needles just so I can get the PRP inside the muscle and multi-layer injection to help provide some healing potential as well as decreasing inflammation. So there's really not a wrong time to send the patient, but it's very helpful if the chiropractor will say, hey, can we do an evaluation for this patient, particularly this area on the right side of the cervical spine, which is very troublesome. So I love it when I get that kind of instruction or direction from a chiropractor upon referral. You know, if I don't get it, then I'll figure it out. I'll just ask the patient where the problem area is. Because the principle of PRP injection is to ask the patient where the worst pain is and ask them to identify the center of that pain. And that's pretty much where you place the PRP injection. And then as you are deep with the needle, you inject as you come out. So you're getting multi-layer injections down to from ligaments and tendons through the muscle bellies themselves. So if we could go to the next slide, I'll address another question. So this is, I get this question often, which is, okay, if you're gonna do this PRP injection, is there an ideal time? If, let's say the patient was injured 2 years ago, is it still reasonable? And the answer is yes. There's really no limit on time when you can do it, because often what you see in someone who has chronic muscle spasm from a spinal injury is on the histologic evaluation. In other words, if you were to look at it under a microscope, the muscle belly develops a scar. So it has scar tissue and it just becomes chronically painful when they try to fire that muscle or move it. PRP does have a regenerative potential through platelet-derived growth factors, vascular endothelial growth factors, and transforming beta factors, all which are within everybody's plasma. And if they're given in high concentrations in the form of PRP, they have the ability of decreasing the scar tissue and actually increasing the way that tissue looks on histological evaluation. So you can change the anatomy and subsequently the physiology of muscle by using PRP. So now I wouldn't use it in the first week or two after a trauma, because a lot of times the patient's own body will break down the inflammation and improve. But anytime after 6 or 8 weeks from an accident on through multiple years after is a reasonable time to do it. Now, you may not have as a great of a result several years out, but you can still have some result. And as we all know, if somebody's in, 7 or 8 out of 10 pain, if you can just get them down to 4 or 5, sometimes that's a big deal for that patient. So if we could, let's move on to next slide there. So the question is, are there any reasons why we can't do a PRP injection? And these are really sort of relative contraindications for prescription blood thinners. I still will occasionally give the PRP because I'm not going into the spinal canal. I'm just going into the muscle and soft tissues. And if the patient really needs it and they understand there's a risk of developing a hematoma and bruising, then I'll do it. What I'll use is a smaller needle and hold pressure for 10 to 15 minutes, and I won't let the patient leave the office until I'm sure there's no bleeding. The other thing to think about is in PRP, there's actually coagulation factors. So when you're concentrating somebody's plasma and giving that, there actually is some evidence that it actually decreases the coagulation time. So that's why I wouldn't recommend doing that in people who are first starting to do it, but there are some cases where it can be done. Coagulopathies, in other words, like von Willebrand's disease, somebody who has a really chronic bleeding disorder. My answer is kind of the same as it is with blood thinners. I wouldn't do it if you're just starting off doing PRP, but as you become more comfortable with it, you can use smaller needles and hold pressure. Obviously, the patient may have a little more bruising. Not ideal, but if there's no way that around it and the PRP is one of the treatments of choice, then that's how we would proceed. And I also might suggest that this is where Dr. Kraft's treatment also may come in handy, because there's no needles or puncture of the skin there. So there's a little bit of a symbiosis between what he does and what we do. I just happen to use needles. Now, if somebody has a low hemoglobin and hematocrit, that's something I'm a little careful on that. So if somebody has really bad anemia, and they need some spinal injections, I probably won't do that because I usually take around 60 cc's of blood for that. That might be a case where the other non-invasive treatment, as per Dr. Kraft, might be indicated. But if I'm just injecting, let's say, a wrist where I just need a few cc's, I might still take blood from the patient because I'm not going to significantly knock down or decrease their hemoglobin or hematocrit levels. So I think that's the last of the slides I had. I just wanted to put out that general concept of doing the PRP and answer some questions I know that would come forward. The one question that came up with Dr. Kraft for his treatment, which I know some of you have in your mind about PRP, is how do insurance companies view the PRP injections? There is actually a CPT code for it. You can Google that. Let me just pull it up real quick. I did it right before we got on. It's 0232T, the letter T. And that was a code issued about 10 years ago that can be used. There are some additional codes that people will try to use in addition to that, but that's kind of the core code that gets used. Since I'm exclusively in the personal injury field, I don't use CPT codes or ICD-10s because I'm not communicating with an insurance company. So in my experience in the personal injury field, I'll just submit what I did, the PRP for the cervical spine or lumbar spine, paraspinal muscles. And we've had some pretty good success with insurance companies viewing it favorably. I can't say that all of them do, but similar to what Dr. Kraft said, that when they recognize the value they're getting for providing patient relief from their pain, I think they're starting to recognize that it's a good value because generally we just do it one time and that's it. So I think the average cost of what it is for PRP is probably right around what the cost is for the no needle epidural. So here we're talking about two regenerative techniques that overall cost less and actually in some cases are more fruitful with pain relief. So the insurance companies are starting to develop more favorable view of it. If somebody does Medicare or PPO patients, I think as long as you submit it before you do it and what the codes you're going to do and what you're going to treat, my understanding is there have been a certain percentage. I think it's still less than 50% from what I'm hearing from my colleagues, but they will approve some form of the use of PRP. Ali, I thought I would open it up to some questions that might be coming in because I often get some varied questions about PRP and I'll be happy to answer those now.
Thank you so much. That was very helpful. Jerry from Doctors on Lean's knees are a hot topic right now. And I will say, I saw Jerry last night and she was jumping up and down. So circumstantial evidence, I think the procedure went very well.
Oh, good to hear.
Personally, I've even had PRP in my knee. I was an avid soccer player before I became an attorney. And I had this dull pain for months. I don't even know where it came from. I did one procedure of PRP in my knee, and that was the last time I ever had any type of knee pain, dull or aching or anything.
Nice.
So I believe in it. I've done it myself. Some of the questions that are coming in are really good questions. So when you withdraw the blood, you have, red blood cells, and then you put it in a centrifuge. That was a little machine that you had. And if you spin it fast enough, the white blood cells and plasma come to the top. So how long do you spin it for? I mean, so a patient comes in, how long does that take?
The whole thing is about 30 minutes. So when the patient, they sit in the chair and I'll draw the blood, I put it in the test tubes and it's 10 minutes at about 3,200 RPMs. And then you get a nice separation of the red blood cells being driven to the bottom of the tube. And then the next layer is white blood cells and then the top part is the plasma. And so then each individual tube, I'll pull the plasma off of that, and then it's all done sterilely, and then it will be injected in the patient under sterile conditions as well. So usually, I think when Jerry came in that day, from the moment she walked in the room, it was 30 minutes till she walked out. The only restrictions I give people for that day is I don't like them to take aspirin after the procedure that day or work out hard that day, but the next morning they can take and do anything they want, understanding that it takes about 4 to 7 days, somewhere in there, to really start feeling a result.
Thank you. That's fair. So you can do the procedure the same day. So you can spin it, inject it, and then the patient can leave that same day. So it's not a few day event or anything like that.
No, it's very quick. In fact, you want to do it quickly. So the PRP, I mean, it's literally still warm when you're putting it back in. You want to, move quickly. So all those, the platelet-derived growth factors and such are, they're still fresh.
Amazing. Do patients ask to be numbed before, or because it's just withdrawing your own blood? You do it without any anesthetics or anything like that?
Yeah, I don't use any injectables for numbing, essentially because for drawing the blood, I use what the Red Cross does, which is a 30-second alcohol massage, which desensitizes the skin for the blood draw. But for the injection, I don't do it because I'm really just doing one shot, for example, in the knee. So to then use a lidocaine injection, you're getting 2 shots and you're introducing a foreign material. So most people will be fine with nothing other than that 30-second alcohol massage on the knee as well, which desensitizes the skin.
Amazing. Thank you. And you can use PRP in joints, hips. I mean, where can you not use it?
Yes, you can use it in any joints. You can use it in soft tissues. You can't infuse it. Like, you don't want to put it into an IV to infuse it. That's not the role of PRP. I kind of briefly shared my experience having done this for about a decade in a previous webinar, but I'd like to summarize it here. And what I've noticed through the years is that it works really well for soft tissues like whiplash, torquing and twisting injuries of the spine. And it works also really well for upper extremity joints like the shoulder, elbow, or wrist. It works well for the lower extremities, but remember, the lower extremities are bearing, weight every day with, could be between 5,000 and 10,000 footsteps each day. So if somebody has a purely degenerative condition, they may have an injection in their knee today and then request another one in 6 months. However, if it's a traumatic injury, like it sounds like you have, Ali, with soccer, where it's a lot of inflammatory component, then sometimes just one, and that's all you ever need.
Amazing. So yeah, I only had it once. So I guess it would be a case by case with the patient, depending on how often they have to come back.
Yes, usually just one will do it. Where we tend to see people require repeats is in the lower extremities, where they're cycling through 5,000 or 10,000 times a day applying weight.
Understood. And you do PRP as well as stem cells, is that correct?
Yes, there's the stem cells. We're just sort of wading into those waters for personal injury. I've done a lot of that overseas, and through some right to try certifications through the state. We've done that on a limited basis. It's interesting. I saw a question pop up about what's the difference between PRP and stem cells. PRP is, the best way to think about it is, let's say I get up from this webinar and go out to get a bite to eat and fall down and scrape the skin off my knee. Well, the first thing that comes to that site, it'll bleed, but it'll be a lot of plasma that comes in to form a clot. And then that plasma starts an entire healing cascade that signals stem cells to migrate from the basement membranes of vascular tissues and organs to come create new skin. So PRP is not a stem cell treatment, but there's no question that there is some signaling of stem cells that there's been an injury and, hey, we need to get into the reparative process here. When you talk about stem cells by themselves, now you're talking about, okay, let's go aspirate some marrow out of the hip, or let's do some liposuction and digest the fat to get the regenerative stem cells out of the lining of the vessels in the fat. That's where you go get the stem cells and prepare them for things like IV infusions and injections. Now that's a whole different level that the FDA is not, they're still, not too keen on that. So if you're going to do it or consider doing it, you have to make sure you go through the state to get a right to try letter for each and every patient that's going to be done for. And it really has to be done in the form of a clinical trial or a study. So I know there's a lot of people who do stem cell treatments. It just, you have to be real careful how you do it. You got to be able to answer questions about it if you're in depositions or trial. So it's not something we've instituted on a routine basis for treatment. It's more of a, okay, let's keep looking into this and do it when it's appropriate.
And thank you. And from your experience, PRP or stem cells, maybe you haven't done too much stem cells, but insurance, auto insurance covering it, how's been your experience with that?
You mean for stem cells?
Yeah, stem cells and PRP. Maybe you haven't done it with stem cells, but PRP for sure, please.
Yeah, the PRP has been, I think it's been looked on favorably. I've been deposed on it many, many times. I've been in trial. I've had to answer questions in trial about it. And I think in general, the insurance companies look at it with a little bit of a, a slanty, like, really? But in the end, I think they see the benefit from it. We have seen in reimbursements that they do look at least favorably upon it in a lot of cases, recognizing that it gave the patient relief and saved them from potential surgeries and more invasive surgeries that are more expensive. So I think it's gaining favor. Stem cells, that's a whole different ball game. You can almost guarantee they're not going to approve anything with stem cells.
Sure.
Now, I don't want to guarantee that, but very few and far between that I've seen them accept that and desire to reimburse for that type treatment. So that you just have to be careful with that.
Absolutely. From my own experience with PRP, PRP has been very helpful in my practice. What I mentioned with Dr. Kraft, the impasse with conservative treatment to injections for PRP, right before surgery. If the client doesn't want to get surgery, they're a surgical candidate, and you're at an impasse, PRPs played a critical role in these cases. And I've had them accepted right away. I've had this same insurance company, State Farm, tell me that it's experimental. So it is case by case, but I think you're right in the fact that it's becoming more accepted, especially I think I mentioned earlier on in 2011 when Kobe Bryant went to Germany for PRP, it was just this big craze for everyone. And I think insurance companies are finally getting on the wagon and noticing that this is an alternative to surgery and it could help and it's cheaper. So why not accept it?
Yeah, I think so. Yeah, there's no question there's long-term savings from it. From people aren't having to take the opioids all the time. A lot of them don't go on to have surgical procedures. So I personally have had it done for a shoulder, my hip, and my knee. So I'm a big believer in it from a personal standpoint as well. But yeah, it's certainly reasonable. I wouldn't call it experimental. It's pretty much becoming part of the regimen in most orthopedic group offices. And I actually just read something recently where some of the OBGYNs are now using it for infertility. I think they're injecting fallopian tubes. Anyway, I'm not an OBGYN, but so I'll stop my discussion there. But yeah, so it's finding its way into different areas of practice.
Perfect. And from a practical standpoint, let's say client or patient is in conservative treatment with a chiropractor. would the chiropractor send them to PRP? Would they send them to you? How does that prescription process go? And then also, after PRP, would they continue conservative treatment, generally speaking?
Yes, that's correct. I think it's, if a chiropractor is evaluating a patient, let's say they're, 12 or 18 visits deep into the treatment and they have certain problem areas, they can send the request to, obviously probably through their representative, their attorney, saying request evaluation for PRP for cervical spine. And then after the injection's done, the patient can literally go back and get right back on the table with the chiropractor, within days.
Amazing. And just from my own memory, I remember they took a few vials of blood for me. How many vials of blood is that?
Well, for like a knee, usually the knee can accept about 10 to 12 cc's pretty easily. Some people a little more, some less. So really it's just a couple vials. So, to draw blood for that, somewhere between 20 and 32 cc's of blood, which is very minimal. And then usually just a couple. If it's a really big person, they may accept more. So it may be 3 or 4 tubes, but it's usually somewhere between 2 and 4.
Understood. And I think you already answered this as far as the body parts, but would PRP be helpful for, let's say, tennis elbow?
Absolutely. So that is pretty easy to access that area. And yes, it would be helpful in conjunction with the use of, a splint if needed, a tennis elbow brace, and activity modification. Again, the thing to remember about it is, it does take sometimes a week or so to really kick in. So, you can't do it and then tell the person, oh, you're going to be perfect tomorrow. It's a long-term process where there's a whole chain reaction of events that occur.
Understood. And I know you spoke about this. You said it's roughly the same price as needle-free laser therapy. Do you have a cost for this type of procedure?
Yes. Well, the range is usually somewhere between 5,000 if you're doing, say, a single joint, or if you're going to the operating room and doing cervical spine, lumbar spine, both shoulders, and a knee, because you can do all that at one time while the patient's asleep. It may be up around high teens or maybe 20. But if you look at the overall average, the average really comes out to about what Dr. Kraft was indicating for his no needle epidural treatments.
Amazing. And a question to both of you doctors. Would either of you recommend no needle treatment or PRP as a viable alternative to help with hip replacement? When there's wear and tear on the cartilage, would either of those be viable procedures?
So I'll go first and then turn it over to Dr. Price. I actually, I personally favor total hip replacement. It's a great surgery. It's actually the hardest joint for us to reach, but I'd love to hear Dr. Price's PRP take.
Yes. Well, the hip replacement surgery, that's one of the most successful orthopedic surgery there is. I think the satisfaction rate's around 96% if you look at the meta-analysis. So if somebody really is hurting and they have a collapsed head or bone on bone, then that's still really the answer. But I do perform PRP for a lot of labral tears of the hip where, let's say, somebody was doing fine with no problems with their hip, and then they were in a motor vehicle accident or a fall and they tore their labrum, and they're not so keen on having somebody stick a camera in their hip just yet. I will do a PRP injection on that. But again, going back to what Dr. Kraft said, if it's bone on bone, it's really best if they just go on and go to the replacement.
I mean, that's very interesting. Thank you for explaining from both of you. I appreciate that. I think as of right now, unless I'm missing, these are the questions. A lot of people want to know your guys' contact information. So again, we'll provide the emails. This is great. And from a personal injury standpoint, from an attorney, it helps us tremendously because us attorneys, we keep hitting the same roadblocks over and over. It's client's injured, doesn't want to treat. Client's injured, doesn't want to do this treatment. And, you know, an attorney is only so creative. And we didn't have the fortitude to go to medical school. That's why we became personal injury attorneys. So I appreciate all of the knowledge. Thank you. I think Riley's going to take over right now, but thank you for both of you coming on today.
A pleasure.
Thank you.
Thank you all.
Awesome. Well, thank you all so much for joining us today. That concludes our Project Pain 2.0 webinar, and I want to say a special thank you to Dr. Kraft and Dr. Price for sharing such informative information regarding treating pain and pain management, and especially Ali Razavi of Razavi Law Group for moderating for us today. Please see all contact information here. As a reminder, Dr. Kraft is located in Manhattan Beach and Santa Monica. Dr. Price located in Newport Beach, Long Beach, Bakersfield, and Riverside. So make sure you grab their contact information. Have a wonderful, wonderful day, and we will see you next time.
Perfect. Thank you and goodbye.
Thanks, guys.
Bye. Thanks.